in treating those people who've been caught up in a disaster, the first thing, of course, to do is to try and rank order the people who are most at risk, and also to identify the resources that are available to be mobilized. But the essential philosophy is that the treatment begins as soon as possible, as close as possible to the incident in question, with the expectancy that the majority of people are actually going to cope. And it is important at even the earliest stage to feed that message into the people who are in a state of adjustment, who are in a state of shock, that they will cope. From there on, one is in a position to follow up those who are seen to be at risk. We generally don't anticipate much use of drugs. The drug that probably we have used most commonly has been a short-term hypnotic, short-term and short-acting hypnotic, if only just to facilitate return to sleep. And sleep disturbance is a very common feature, especially sleep disturbances associated with unpleasant dreams, sometimes amounting to nightmares. We also draw attention to the need for correction of the carbohydrate imbalance. When people have been exposed to a very frightening experience, they need their energy to be restored, and there is no doubt about it that the Salvation Army have hit upon the right answer. Produce a tea wagon with big pots of tea, heavily sugared, big thick wedges of sandwiches, and they're doing two things. They're restoring energy to the people, but they're giving them an opportunity to get together in a normal fashion. It's not the frank psychotherapeutic group that people fantasize about. Most people are used to going up to a tea bar, getting a mug of tea and a wedge, and standing in small groups around the tea bar, and that's the sort of philosophy that we would advocate.
Very often people find groups of people working with a facilitator, people who've had a similar experience. There's something very powerful in that sort of solidarity. Many people are helped that way, and many people were helped after Clapham that way, and the groups then having a natural ending point. But a recognition that for some people it will reawaken painful and difficult memories and experiences that long antedated the accident or incident, for which proper counselling, psychiatric or psychotherapeutic interventions will be necessary. But paradoxically, the person I would be most concerned for would be the greatest hero and the greatest coper. Because I think the message that comes out of following up all major disasters is the greater your propensity to be a hero and to cope magnificently, the greater your propensity to take a fall and to become a victim.
I think staff are very worried about media interest. They're very concerned about voyeurism. They're very concerned to maintain the confidentiality of patients and of themselves, because they don't always want to talk about their own feelings. And the media are very interested in that, always, about how nurses felt and how patients feel, and does anybody have any hatred towards what's happened. And I think nurses feel very strongly that they must protect patients, particularly from this type of voyeurism. It is difficult because sometimes the media will go to almost any lengths to step inside our circle of confidence and find out how patients are feeling and what they look like and how they feel about themselves looking like that. And it's all too soon. In the midst of disaster, people need time, and the last thing you need is voyeurism from the media or the general public. People need time to recover, and staff need time to recover too.
If you're involved in a major incident, you are well aware that there's a very thin line between appropriate concern and persecution, and indeed between research and voyeurism. There's something, I think, about the prominent people who suddenly descend, and indeed the press. For example, if I were doing the thing again, I would want to be quite sure that the people who were interviewed by prominent people in the presence of the press really gave an informed consent to such interviewing, because my guess is in most cases those people were on, if you like, an adrenaline-induced hype and didn't know quite what they were saying and quite what they were consenting to.
And it was another 3/4 of a mile beyond that point that the Herald of Free Enterprise went down with her doors still wide open.
I feel much better today, and I'm in a bit of pain, but I'd never go on a boat again. Never. It's really put me off going on a boat for life.
The advice I would give to non-expert staff, and by that I presume we're talking about non-psychiatric staff, non-social workers and non-chaplains, is to continue to do the things that they've always done, but to be more aware of the need to support each other, especially in the immediate aftermath. And there is also a particular piece of advice I would like to give them, is that it is even more common on those occasions to become identified with the patient, or rather for the patient to become a special patient, and sometimes that needs to be guarded against, because there is then the problem of letting go when that patient has to leave the ward or be passed on to another caring community.
People are actually very well resilient, and people who are properly supported will let their natural defence mechanisms work, and we often need those defences. That isn't to say you don't give support and care, but it's support and care that always has to recognise the fact that we do have defences and ways of coping.
Although President Tito has promised to rebuild Skopje, only time can heal the wounds to minds and bodies or restore the shattered lives of the homeless and bereaved.